Hi everybody, it's Len from Irishdermtutor.com here, and for this portion of the website we're going to talk about atopic eczema, which is obviously one of the commonest inflammatory conditions we see in dermatology. So just as a brief overview, we'll go through a bit of an introduction, then go through clinical presentation that we might see, a bit about infection and pathogenesis, and then we'll move on to management, so how we do a severity assessment, how we manage it with topical treatments. We'll talk a bit about phototherapy, and then we'll move on to the conventional systemic agents that are used. And then finally, we'll talk about some of the newer agents out there, so some of the biologic agents that target cytokines, and then we'll move on to JAK inhibitors. And I'll then do a brief summary of the relevant trial results to date. So as with all the areas on this website, if you want a quick reference and you want to look at something quickly, so for instance, if you just want to a memory aid for fingertip units, you can click on fingertip units and it will jump down to that section. And then if you want to go back to the top, you can go to the top left here and click back. Okay, so let's get started. So atopic eczema, let's go back to the top. So, atopic eczema is one of the commonest diseases we see in dermatology. The large majority of patients who do get atopy will develop symptoms or signs by the age of 5. Now, with regards to prevalence in the UK, approximately 25% of people under the age of 5 could have it, with a range of about 15 to 44%. And then that decreases with age to account for only about 5 to 10% of adults. There seems to be a higher prevalence in Australasia and Northern Europe compared to the rest of Europe and Asia. And severity of disease tends to get better with age, but patients may always still carry a predisposition to it. And this might make them more sensitive to things in the environment like irritants and allergens. And this might be important for patients to remember, as it may predispose them to occupational to skin disease when they start their jobs. So for instance, hairdressers might be coming in contact with a lot of wet work, and that their hands might be more sensitive to dermatitis. So, as we all know, atopic eczema has associations, including the atopic triad. So, prior studies suggested that maybe 25% will go on to develop asthma and maybe 75% will go on to develop allergic rhinitis, although recent studies suggest that maybe these associations are not as high. Patients are also more prone to get food allergies, and they're more prone to getting skin infections as you have reduced cellular immunity found in the skin in this condition. So they're more likely to develop skin bacterial infections, fungal infections, and importantly viral infections such as herpes simplex. So there's something called the hygiene hypothesis with eczema, and this suggests that eczema essentially eczema prevalence has increased by about 2 to 3 times over the last 30 years, and this has given rise to this hygiene hypothesis. And in a nutshell, this suggests that the cleaner the environment you grow up in, the more likely you are to have eczema. So early exposure to microbes and products of microbes may help steer the immune system away from atopic dermatitis and other allergic diseases. So if you are less exposed to allergens and infections early in life, you may be more susceptible to autoimmune and allergic diseases. And studies have suggested that things like early exposure to older siblings, or if a child goes to creche early, or if you have a pet, like if you own your own dog, this may protect against atopy. Another concept is the atopic march, and this refers to the natural history of atopic manifestations over the course of a life within the general population. So initially, young patients will present with an atopic dermatitis or food allergies, and then these become less common with age. Then a bit later, the atopic population will often develop asthma, and again this can increase as they get a bit older, and then as they go into their teens it plateaus and then it decreases. And then finally they tend to develop hay fever, and this can increase up until adulthood and then can persist. So adults will most likely have an allergic rhinitis. So recent literature supports a causal link between atopic dermatitis and later onset atopic disorders. So essentially, if you have a dysfunctional skin barrier, it lets allergens in where they shouldn't be. So really the allergens are being introduced through the skin rather than in other areas. So for instance, the gut in the case of food allergy. So the skin gets these food allergens and it doesn't react to it in an appropriate way, and it leads to an abnormal immune systemic reaction in the area, and this predisposes the patients to allergies. So they might be predisposed to hay fever, asthma or food allergy. So eczema is generally a clinical diagnosis. Usually you don't need a biopsy or any other investigations to diagnose it. Patients will have very dry skin and it's associated with a red scaly rash, and it invariably is an itchy condition. Patients may often have secondary changes, so because they've been scratching you might see lots of scratch marks and excoriations. And as with chronicity and constant scratching, the skin can become thickened and lichenified. And lichenification means exaggerated skin markings. I will show some images in a second. If the skin does become very weepy or crusted, it's often a sign of secondary skin infection. And then with time, the skin can become dyspigmented, so it can become hyperpigmented or hypopigmented, and this is often more pronounced in darker skin types. So there is a UK diagnostic criteria. I don't know does anyone actually use this in practice, because as I mentioned, it's usually just a clinical thing that you notice, and if you've seen enough of it, you can usually pick it up pretty quickly. But the UK criteria is that it's an itchy skin condition plus 3 or more of the following. So often the rash is in a flexural distribution, or it can be on the cheeks only if less than 4 years old. They often have a history of asthma or rhinitis, or a history of atopy in a first degree relative. They generally have dry skin over the past year. They often have visible flexural eczema, or eczema on the cheeks, forehead or outer limbs if less than 4 years old. And the onset of symptoms has usually been within the first 2 years of life. So eczema changes with age, so the pattern of eczema you see depends, particularly in the early years. So there's an infantile phase which goes from about 0 to 6 months, and often these children will have quite bad seborrheic dermatitis, or what is referred to commonly as cradle cap. They'll often also get eczema appearing on the face, so the cheek, the chin and the forehead. So here you can see this little baby has quite inflamed eczema affecting the cheeks and the chin, and it looks like it's slightly weepy, and you can see there's little erosions along the cheeks. But it can present anywhere in a child this age, so it can be widespread. Interestingly, the diaper area is usually not affected in this age group, and this is because the moisture in the area protects the skin. And as I mentioned, the skin can look very red, weepy and inflamed. Then as the baby gets older and the baby starts crawling, so around 6 to 12 months, you might actually get the rash appearing on the extensors of the elbows and knees, which kind of goes against what we always say about eczema, where it occurs in the flexors. And this is probably because the baby can easily scratch at the area as they begin to crawl, and they might get the extensors irritated as they're crawling along. Then the childhood phase, kind of from around, I suppose 1 or 2 years of age to 10 years, it then begins to take mainly flexural presentation in the majority, in the classic presentation. So usually common areas affected would be the flexures of the elbows, the knees, the wrists, the ankles and the neck. And here you can see flared eczema affecting the flexural areas of the skin. And then with chronic rubbing of the skin, you get this thing. So sorry, here's one image of flexural eczema. Here's in a lighter skin type eczema kind of on the flexural aspects of the arms. As you can see, it's very dry skin and it's red and inflamed and scaly. And this is what I call lichenification. So here you can see there's exaggerated skin markings and thickening of the skin. And as I mentioned before, this is usually worse in darker skin types. As well as the flexural areas, can often affect the perioral and periorbital areas. And then it is, if you get a flare of the skin and it gets secondarily infected, you'll notice that the skin's become oozing and crusted. So then as patients tend to get older, so as they move into adolescence or into their adult phase, you might actually notice that the atopic dermatitis improves in a lot of areas. However, they may still get the flexural eczema, and then they might also get it to become more localized. So oftentimes it might just become localized to tricky areas such as the hands or the periocular areas. And these areas are always going to be more sensitive to various irritants or even allergens in the skin. And just to note that with severe eczema, so as you get old, you can still have severe widespread eczema, but you might also get things secondary to chronic scratching. So lichenification is due to scratching, and sometimes you can also get these small thick nodules, and that's due to chronic rubbing, and these are called prurigo nodules. I don't think I have an image of them here, no, but essentially they're thick nodules that are very itchy, and as they're itchy the patient scratches and they become thicker as a result, and it's really a vicious cycle. And here's just kind of an example of periocular eczema. So what are the clues to diagnosis of atopy? So sometimes if you're not sure, you can check a few other things. So atopic patients may have something called ichthyosis vulgaris, and this essentially is a condition where you get markedly dry skin. And this is due to something called a filaggrin mutation, and I'll discuss this later, but they might also have some other signs. So if you look at the palms of their hands, you might note that they're very hyperlinear, and they might also have a thing called keratosis pilaris, which is basically little kind of bumps that are around the hair follicles, and they're often seen on the upper arms in people, and they're very common. So I'll now move on to some subtypes of eczema. So discoid eczema is quite a common subtype of eczema that can occur in atopic eczema. And as in the image here, you get these scattered, rounded, quite thick patches of eczema, and they can be very itchy. And you often need quite a potent topical steroid to get this discoid eczema under control. And you might need to even put the steroid under occlusion so that it can penetrate into these discoid areas. There's also something called pityriasis alba, and this is a common manifestation of atopic eczema in younger people. It's more noticeable in darker skin types. So as you can see here, you get a hypopigmented area. It often is on the face. And I remember the first few times I saw it, I was thinking that it could be vitiligo or something like pityriasis versicolor. Vitiligo would not have scale associated with it, and vitiligo would be, there'd be no pigmentation at all within it. And so pityriasis alba, oftentimes it's just a bit hypopigmented to the surrounding area, and oftentimes there's a bit of scale that's noticeable. So it's important, as I mentioned before, that you're aware that infection is more common in atopic skin, and it can be any infection. So it can be a bacteria, viral, fungal, or even molluscum contagiosum. So with regards to bacterial infection, so if the skin is particularly weepy, or you see that honeycomb color of impetigo, you want to think bacterial infection. And if you were to swab all atopic dermatitis patients, you'd find that a lot of them are colonized with Staph aureus. And I appreciate that's a wide range of 30 to 100% depending on the study you look at. But in colonization with Staph aureus increases the risk of infection. And it's important to be aware that MRSA is more common in atopic dermatitis patients. So about 11 to 34% of atopic dermatitis patients colonized with Staph aureus have MRSA, and this is associated with more severe eczema. So if you have an eczema patient who is very resistant to treatment, you should consider swabbing the skin to make sure they don't have MRSA. And if it is picked up, you look at the local guidelines, because they may differ between sites, but one such eradication example is using mupirocin in the nares of the nose 3 times a day for 5 days, and then an appropriate wash such as octenocin daily for 7 days. And I do talk a bit more about the microbiome and MRSA at the very end of this section of the website, so if you want to skip to that, you can click here on the website. There is something called PVL Staph aureus. PVL stands for Panton Valentine leukocidin, and this is a toxin that is produced by certain types of Staph aureus. And this toxin can kill white blood cells, and it can actually cause damage to the skin and the deeper tissues. So this can present in patients with cellulitis, abscesses, boils, or folliculitis. So if you see an eczema patient who's getting recurrent areas of folliculitis, or if they're getting recurrent large boils, you want to swab for this. And it's important that when you swab for it, that you mention that you're looking for PVL toxin. Otherwise, they're not going to test for it. And then you can also get group A streptococcal infection in patients with atopic dermatitis. And these patients you may often see pustules within the skin, and sometimes it can be painful. So a very important condition to be aware of is eczema herpeticum. And this is a dermatological emergency, and it occurs when the atopic eczema becomes secondarily infected by the herpes virus. So as mentioned before, skin in atopic eczema is considered immunosuppressed. So if someone gets a cold sore virus and they've got atopic eczema, it can spread really like wildfire. So you suspect this if a child who otherwise had relatively well-controlled eczema gets a sudden flare-up and is very unwell. The child might have fever, might be unwell, and they might have lymphadenopathy. And what you want to do is you want to look for small little blisters. Now, unfortunately, this is not a great image. This kind of golden crust is actually bacterial infection, but you might be able to appreciate these small little punched out erosions. So what you're looking for are tiny little vesicles or punched out erosions. And if the eczema herpeticum is around the eye, you need urgent ophthalmology follow-up as well. If it involves the eyes, they are at risk of corneal scarring, so it needs to be treated and managed appropriately. It's important to recognize this early and put the patient on antivirals, depending on the severity. If it's quite mild, you might give oral antivirals. If it's quite severe, they might need IV. And when you're looking up the dosing of the antivirals on the BNF, for instance, you want to use the immunosuppressed dose. As I mentioned before, the skin is locally immunosuppressed in eczema. So acyclovir can often be used, and famciclovir probably shows better bioavailability, but so maybe slightly more effective, but it's also more expensive. And as in this image, they often get secondarily infected with bacteria. So you look for any crusting and you treat with antibiotics. And then you can also get infection with a Coxsackie virus, something called eczema coxsackium or chickenpox, and these can cause quite similar pictures. When it comes to pathogenesis, a complex range of factors are at play, including skin barrier dysfunction, immune dysregulation, environmental factors such as allergens and an altered skin microbiome, and genetics. And their relative roles and whether they are all interrelated is really still not fully understood. As it is very complex, I'll try to go through a relatively simplified version, but hopefully this will give you a better understanding of the various current therapeutic approaches. So traditionally there's kind of two ways to conceptualize it. So one was that the primary problem was that there was a barrier defect, and then this led then to immune dysregulation, and this was called the outside-in theory. And then the other one was that their primary problem was actually immune dysregulation, and this then led to barrier defect, and this is called the inside-out theory. So I'm going to talk first about eczema as a barrier defect. So keratinocytes in the skin start out in the basal layer, and during their life cycle they work their way up to the surface. And at the surface, they become flattened and they lose their nuclei and organelles, so essentially dead, and they are known as corneocytes. The outermost layer that is composed of corneocytes is called the stratum corneum. Now, the stratum corneum provides the majority of the barrier function in the skin, and you can think of the stratum corneum as a brick wall. So the bricks are the corneocytes, and then the material between it, which is lipid-based, can be thought of mortar or cement. So what happens in eczema is you get a barrier defect. So first of all, you can't keep water into the skin as efficiently, and this leads to dysfunction of the skin. And then also it lets things from the environment, such as air pollutants, bacteria, irritants, or allergens, get into the skin. And some of these allergens or other things can be introduced to the dendritic cells of the immune system, as shown in this diagram. And this presents signals to the T helper cells, and what you get is a shift away from T helper 1 cell activity to T helper 2 cell activity. And this means that T helper 2 cells leads to an increase in the signature cytokines that result from this pathway. So you get an increase in cytokines interleukin 4, 5, 13, 31 and 33. And just of note, IL-31 is a cytokine that produces itching, and some newer agents target this. And then with this increased inflammation, you get red skin, of course, but you also get itch. And as a result, the patient scratches, and as they scratch, that further disrupts the barrier at the top. And this allows more antigens, bacteria, or whatever into the skin, and as a result, this makes the eczema worse. So the Th2 cytokines I mentioned do a few things. They can downregulate important proteins in the skin, such as filaggrin, and I'll mention that in a bit more in later. And they also facilitate the fact that you can become more sensitized to various allergens in the skin. And then as time goes by and you have increased inflammation of the skin, the T helper cells can change. So you can also get increased T helper 17 cells, T helper 22 cells, and T helper 1 cells. And in general, you just get lots of inflammation and multiple cytokines. So this is a really simplified version of the eczema pathway. As I mentioned, it is very complex. It involves environmental factors that further degrade the barrier. Sometimes chemicals can be released from keratinocytes that can increase inflammation, and you can also get increased eosinophils and increased production of IgE. But it can all get quite complex, so I won't go into that in much more detail. Now, I have mentioned filaggrin before, and I will just mention that genetics definitely play a role in atopic eczema, and there has been in recent years evidence of specific genetic mutations that can contribute to atopic eczema. So as I mentioned, there are multiple genetic factors and that can have been identified, and they can lead to a defect in the skin barrier. The most well-known one is filaggrin, and there have been at least 20 loss of function mutations which can cause a filaggrin deficiency. And a lack of protein in this skin causes an inherited dry condition called ichthyosis vulgaris. And if you have ichthyosis vulgaris, it is strongly linked to the development of atopic eczema. So I'll just show you here. So if filaggrin is vital for skin cells to mature into the tough, flat corneocytes that form the stratum corneum. Filaggrin is broken down is formed from the breakdown of profilaggrin. So if you look where my mouse is here, you can see little granules in the stratum granulosum, and these contain profilaggrin. And once this is cleaved, the liberated filaggrin binds to and collapses the keratin cytoskeleton. And this results in flat corneocytes that are aligned parallel to the outer surface of the epidermis, and this improves barrier function. Therefore, if you do not have filaggrin, you do not get the corneocytes aligning and becoming flat properly, and as such, allergens can easily enter the skin, and they can be presented to antigen-presenting cells, which stimulates an immune response. Also, filaggrin contributes to other things, so its degradation products are important in retaining moisture, and they're called natural moisturizing factor. They also play a role in killing bacteria and maintaining skin pH. Therefore, if you do not have enough filaggrin, you get impaired barrier function, inability to retain water, dry skin, abnormal pH, and too much bacteria. So it is an important protein. It has been found that filaggrin mutations are associated with increased risk of atopic eczema, increased risk of allergic sensitization, and increased risk of peanut allergy. But it's very important to note that not all cases of eczema are related to filaggrin issues, and 70 to 80% of eczema cases worldwide have no filagra mutation. And filagra mutations are found in about 18% of British cohorts. And that's old data. I'm not sure if that's changed, but that was reported data previously. And there are other genetic candidates that are being explored which likely also cause impaired barrier function. And this may be as a result of increased proteases in the skin, which can break down important proteins, or decreased protease inhibitors, which leads to the same result, or problems with adhesion proteins between corneocytes. And again, I won't go into that in too much detail. Now, I'm sorry, I know that was quite long-winded, but hopefully that will give you a better appreciation of the pathogenesis of eczema and why we use some of the treatments we do. So when dealing with a patient with eczema, it's very good to do a severity assessment. It really is good to assess how much the eczema is affecting the patient also. So particularly for children in particular, well, or I suppose adults equally, you should always ask about sleep disturbance and if they're missing days of school and work. There are quality of life questionnaires which are easily downloaded from the internet or will often be found in clinics. So there's DLQI, which we use also in psoriasis and many other skin conditions. And this is how it affected your quality of life over the last week, and it is scored out of 30. And then there's something called the POEM, which is a patient-orientated eczema measure. This is more specific to eczema. And again, it asks about how it affects your quality of life. It's scored out of 20. Now, I've mentioned here it was over the last week, and perhaps I might be wrong about that. It might be over the last month, so you could look that up yourself. But again, they're both questionnaires that can assess how badly the eczema affects your quality of life. And then there's a clinical severity assessment score, and there's an EASY, which essentially is like the PASI, but for eczema. So it breaks up the body into 4 regions. So the head and the neck is one, and then the trunk, upper limbs, and lower limbs are the others. And you assess the area affected in each region, and then you look at things like redness, thickness, scratching, and lichenification. And again, you get a combined score. And a SCORAD is another severity assessment score that is sometimes used that I will not go into detail here. So the management is obviously very important and how to deal with eczema. So in general, there are just some general tips that you want to counsel the patients about. So it's very important to take time in the first consultation to tell them what eczema is and the rationale behind using various treatments. Sometimes you might use the analogy of a house made with brick walls, as mentioned before. So you can say that it is very important that you continually repair the walls of the house, and emollient is very important in keeping it well maintained and in good condition. But unfortunately, sometimes the house might catch on flower, i.e. the skin is red, and then you can use topical steroids or other anti-inflammatories to put this fire out. And it's very important to counsel them that if steroids are used correctly and in a supervised way by a dermatologist or by a doctor who knows what they're doing, that it is very safe. And in fact, if the steroids are used correctly, in the long run, you'll probably need to use a lot less than if it's used just sporadically and in a haphazard fashion. So with regards, it's very important to have a good cleansing regime. So soaps, shower gels, shampoos, bubble baths, all these things are very irritant and should be avoided. So you should consider a soap substitute or an emollient bath additive instead. You can also use these to wash the hair. And also fragrances and perfumes, most of them are known irritants to the skin, and where possible they should not be used. For instance, obviously a lot of atopic patients will be children, so when bathing a child, you probably should only use the bath for about 5 to 10 minutes. Now, bathing is encouraged, but as soon as it's finished, you should pat them down with a towel instead of rubbing the area. And then you use a greasy ointment such as emulsifying ointment, or what we have in the UK is usually 50-50 or something like hydromal ointment. And you use this as soon as they're out of the bath, and this will lock in the moisturiser. So example of soap substitutes that are used in the UK include Dermal 500, QV Gentle Wash, Hydromal Bath and Shower, and Double Base Emollient Wash Gel. And then some bath additive examples include Oilatum Junior Bath Additive, Hydromol Emollient Bath Additive, and Double Base Bath Additive. So emollients or moisturizers are really the cornerstone of managing atopic patients. It's really key, and you want really want to encourage as much emollient as possible. And when estimating how much emollient is enough to prescribe, you want to kind of estimate how much they're using. So, for instance, if you want them to have 2 applications a day for 1 week, that means an adult will probably need 500 grams and a child will probably need 250 grams. When using an emollient for children, we will often ask the parent to use a clean spoon when taking the emollient out of the tub, as if they reach in with the hands, that can introduce different bacteria into the tub. So it's better to use a clean spoon. And in general, our advice is that the greasier an emollient is, it is better at hydrating the skin. So something like 50/50 ointment or Hydromal ointment are the best things to hydrate the skin. But it's often difficult because it is very greasy, so parents or patients might not like using it due to it being greasy. So oftentimes you might have to compromise and say that that you can use a cream. Now, the issue with creams are that they contain emulsifiers, preservatives, and different antimicrobials. So they might sting when you use them, and you can also develop contact allergies to them. And ointments have less ingredients, so you're less likely to react to an ointment. So as I mentioned, it's oftentimes about finding the balance. You know, if you only prescribe an ointment, they might not use it. So sometimes they might make compromise and say, maybe use a cream during the day and then use an ointment at night. So it's all about finding the right balance with the patient or parent. So common emollients that are used in the UK, so ointments include Hydromal ointment, Epiderm ointment, Diprobase or Cetraban. And then I from memory, emulsifying ointment tends to be the one used in Ireland. And then with regards to creams, there's Diprobase cream, Cetraban cream, Aveeno cream, among others. And again, the one in Ireland I remember we used to give was Silcox base. And here is just a table there that I've mentioned of different creams from light consistency to greasy consistency on a spectrum. So for instance, Zerovene, Balneum and Double Base are all very light. And then on the other end of the spectrum, you've got Hydromal ointment and 50/50 ointment being the greasiest. And one thing that sometimes comes up is parents may ask if a child can go swimming, and in general, you don't want the child to miss out on swimming, so you could say it's okay to go to swimming pools, but you probably advise them to moisturize the baby before swimming. You then obviously want them to use a whole body swimsuit, as they might be too slippy otherwise if you've just moisturized them. And then importantly, as soon as the baby is out, use a soap substitute if possible. This will help wash off the chlorine, which can be very irritating, and then you moisturize them right away. So we'll now move on to topical steroids, and again, it is very important in managing eczema. And oftentimes parents or patients might have a steroid phobia, but in general we say if it is used correctly and as prescribed, they are very safe. It is important to use an appropriate strength of steroids depending on the location of the rash and the patient's age. So in general, we use weaker steroids in areas of thin skin, such as the face and eyelids, and we can use stronger steroids in areas of thick skin, like the palms, soles of the feet, and the scalp. And obviously, we can use stronger steroids in adults, and we might have to use weaker steroids in a pediatric population. So the common steroid potencies, now you'll see that there really are a huge amount of steroids out on the market, but these kind of are the ones we commonly use. So a weak steroid is hydrocortisone 1%, and then moderate is Umivate or Betnivate or D. Another one we sometimes use is Sinular 1 and 4. And then sometimes if they've got cracks or fissures on their hands, you might use something called Helan tape, which is tape that has fludroxycortide infused into it. Then moving on to the more potent steroids, you've got Betnivate, Elicon or Sinular, and then super potent, which is the strongest we have, is Dermavate. And all of these come in either cream or ointment form. Some of them come in lotions or gels also. So Sinular comes in a gel, for instance. And then sometimes you can use combination of topical agents. So for instance, Fusidin H is hydrocortisone and Fusidin, which is a weak steroid and an antibacterial agent. Dactocort is a nice one. It's hydrocortisone and clotrimazole, so a weak steroid and an antifungal. And that's often good for the flexural areas, as oftentimes you'll have superimposed fungal infection in rashes in that area. Betnivate C is a strong steroid with an antibacterial agent. In general, I find it's preferable to Fucibet, as resistance to Fucidin is becoming more common. But Fucibet is also something that's used, which is a strong steroid, and Fucidin, which is an antibacterial agent. Trimivate is a cream that I'd often prescribe for flexural areas to get things under control. That contains a moderate steroid, Umivate, as well as an antifungal, which is and an antibacterial, so neomycin and oxytetracycline. And then Lotriderm is a strong steroid with an antifungal, and Dermavate NN is a very strong steroid with an antibacterial and an antifungal agent. So really you can use these to if there's any weepiness, you might want to use an antibacterial agent. If it's in a flexural area, you might want to use an antifungal. So they're quite useful treatments to have. As mentioned before, generally ointments are preferable to creams as they have less preservatives in them. And steroids should work quite quickly. So for instance, if a child is not responding to a steroid within a week, and it's an appropriately strong steroid, then there's a few issues. You might not be using enough steroid is not strong enough, or something else is wrong. For instance, they might have an allergy to the area, or they might have a food allergy that keeps exacerbating the rash. But the key thing is you want to use the right treatment as a trial in the first instant. You don't jump in your diagnosis to food allergy right away. You want to use the right steroid first, and then if things aren't working with the right steroids, then you need to think is something else going on. So there are obviously many potential routines for topical steroid use, but for one example is such that if a flare is present, you'll give the appropriate steroid strength for an appropriate amount of time. So you might give it for once a day for 7 to 10 days. In general, there is no major benefit from using a steroid twice a day, especially with single steroid preparations. Some of the combination ones you might use twice a day. But then once the rash is under control with that routine, then you can suggest that they can continue to use it twice weekly as maintenance. And in general, using it twice weekly won't cause any long-term effects, and it's actually been proven in studies that using a twice weekly maintenance regime over a long period of time, it's better at reducing flares, and as a result you probably use less long-term steroids. So it is important though to be wary that they aren't using too much topical steroid, or that they are using enough. And fingertip units are a useful measure of how much steroid is needed to cover particular body parts. So 1 fingertip unit is enough to treat an area of skin twice the size of the flat of the hand with fingers together. So I'll say that again. 1 fingertip unit is enough to treat an area of skin which is twice the size of the flat of an adult's hand with their fingers together. And 1 fingertip unit, which is essentially what a fingertip unit is on the index finger, putting steroid from the first crease of the finger to the distal finger. And 1 fingertip unit translates to about 0.5 grams for males and 0.4 grams for females. And essentially 1 fingertip unit should cover a hand, 2 fingertip units covers a foot, 2.5 the face and neck, 3 the arm, 6 the leg, and 14 the trunk. And obviously that's for adults, and it's different for children. But I suppose the really key thing is that an adult body is approximately 40 fingertip units, which is 20 grams. So 1 application should amount to 20 grams. And for children, this is less. So up to the age of 4, it's about 6 to 7 grams, and infants from 6 months to 1 year is about 5 grams. So I know that's a bit word heavy, but really this is, if you're ever in clinic and you forget what fingertip units are, you can skip to this section of the website. So and then in general, I've just got a summary there. So head to toe treatment for adults is about 20 grams daily. So daily treatment for 1 week should be about 140 grams. And then on the opposite side, a child that is 6 to 12 months, it's 5 grams daily. So treatment for 1 week should be about 35 grams. And I've got fingertip units according to age listed there. So we'll now move on to topical calcineurin inhibitors. And these are creams, they're basically topical tacrolimus or pimecrolimus. and they are often used as steroid-sparing agents, and they're particularly good for the face and flexural areas. The thing about them is that oftentimes patients report that they burn and sting when they use them, so they stop using them right away. But it does tend to get better with continued use. So you should advise them to start using it when the skin is not too badly inflamed to prevent stinging. And sometimes you might even use a topical steroid for a few days concurrently to get the flare under control. And then they can stop the steroid and continue with the topical calcineurin inhibitor. So one of them is called Elidel, it's called Elidel, and that is pimecrolimus, and it's about a third as potent as full-strength tacrolimus. And then you've got Protopic, which is tacrolimus, and it comes in two strengths. The 0.03% is licensed for the age of greater than 2, and 0.1% is licensed for greater than 16 years old. Now, I do know that lots of people do tend to use the 0.1%, possibly in younger age groups than that. And you can do different routines. It really depends on what you're kind of comfortable with. So, if they've got an acute flare, you might use it twice daily for a few weeks, and then you might use it twice weekly up to a year, and this can reduce the number of eczema flares. Or sometimes you might use topical steroids for a period of time and then switch to Protopic. It really depends. I'd often on the face, I might say in a child, I might say if they get a bad flare to use Humavate for 3 days, and at the same time they could maybe consider using Protopic as well, and then maybe continue Protopic for a few weeks, and then try to reduce it down to twice weekly, and to see if that keeps it under control. Now, side effects, so increased HSV infection has been reported, so you do ask them to stop it if they develop cold sores, but generally I don't find this to be a major issue. And then there was a black box warning about it, that there's a risk of skin cancer. And I think this is really because when it's used in transplant patients, systemic tacrolimus is definitely an increased risk of skin cancers. But this doesn't appear to have been borne out with the topical treatment yet. So there's a study called the Apple study, and they found that there's no evidence that topical tacrolimus increased long-term cancer risk in children after being used after 10 years of follow-up. And in those cases, children must have used tacrolimus for at least 6 weeks. Now, I won't go into major detail, but there are some novel topical agents that are coming out. I'm not sure if they will come into common usage. I haven't really been using them at all myself in practice. I don't even know if they're available in the NHS, but there's something called crisaborole. That's a phosphodiesterase inhibitor, so it's like topical apremilast essentially, and apremilast is something we use for psoriasis. It was licensed in the USA since 2016, but its effect probably is quite moderate, and it was recently FDA approved in December 2020 for infants greater than 3 months. And then there's ruloxitinib. Now, JAK inhibitors are used systemically now for eczema and many other conditions in dermatology and in other specialties. And a phase 2 study in 2000 showed it might be superior to mid-strength steroids. And some reports an 80% of easy in some sites. And so there are some studies about that. Again, I don't know how expensive it is or how practical it will be used, so I suppose keep an eye on that one. Occlusion is something else that can be sometimes helpful in eczema that's difficult to control. It can be beneficial by improving hydration, steroid penetration, and it can act as a barrier to scratching. There are various methods, including paste bandages, wet wraps, garments, and occlusive dressings. And really good education for the family or for the patient is needed on the use of occlusion. Again, the BID website has a good informational videos, so skinhealthinfo.org.uk, and you go to support and resources and video guides, and they've got very good videos about how to apply occlusive dressings, paste bandages, and wet wraps. So just something to be careful with occlusion is that sometimes it will increase the potency of steroid. So you need to make sure you use steroids in appropriate areas and not for too long. Definitely don't use occlusion in the face or in flexural, in kind of the flexures of the groin or the axilla. And it can also exacerbate an active skin infection. So don't use if the skin looks secondarily infected. So I'll talk about paste bandages, which are single-use bandages only, and they often contain an amount of zinc oxide. So there's Ictopaste, which contains about 6% zinc oxide, Viscopaste, which contains 10%, and Zipsock bandages, which contain 20%. So the Ictopaste and Viscopaste are essentially cotton wraparound bandages. So they're kind of the classic wraparound bandages that you have to do up yourself. Whereas Zipsocks are cotton stockings, so oftentimes they're easier to apply than the wraparounds, but unfortunately children tend to be too small to use them. All these bandages have soothing and anti-inflammatory effects, and they can also improve penetration of topical steroids and the hydration of emollients, and this is due to the occlusion. It is important to note that you need to cover the bandages and stockings with another type of tubular dressing, and this helps avoid soiling of the clothes and also helps to keep them in place. One tip, a practical tip, is that you can put paste bandages in the fridge before application, and this can be quite soothing then when the bandages are applied. And in general, the bandages can actually be left in place for 7 days, but obviously oftentimes you'll want to change more frequently, as they'll need to be get emollient onto them and plus or minus topical steroids. So wet wraps are another way to provide occlusion, and usually you'd use an emollient underneath, and that helps with emollient, but you can also use topical steroids underneath, and again probably should only do this for short periods of time due to the increased potency that can occur with occlusion. So when applying it, you'll often use garments. So I mentioned garments a bit lower down, and some garments are appropriate for wet wraps, so you just need to make sure that they are. Or else, if they're smaller areas, you could even just use tubular bandaging. But with the garments, you'd often want 2 tops, maybe 2 leggings, and then you'd want a basin of warm water and emollient cream. So what you'll ask the patient to do is that they wash the usual way they do, and then you apply a thick layer of cream. Now you tend to use this more than ointment, as sometimes the ointment might predispose them to getting a folliculitis type picture under occlusion. So you use a thick layer of cream, and then you prepare the wraps by putting 1 top and 1 leggings in a bowl of warm water. You then squeeze it of excess water, and you want the garments to be damp but not dripping wet. You then apply them quickly to the patient. Try to make sure things like labels and any seams are on the outside so as they don't irritate the patient. And then you put the dry top and leggings on top. Now you can leave wet wraps on for 24 hours, but I think common practice is just to leave them overnight and take them off in the morning. Now again, you need to be cautious. If they have a skin infection, it could make it worse. And also, particularly if you're in the UK and Ireland, you know, if you're putting it on in cold weather, you know, it can be very uncomfortable. So you just need to kind of be practical about whether you're going to use it or not. Now there are various range of eczema garments. They're sometimes called eczema clothing as well, and they're supposed to be designed for individuals with kind of eczema and other similar conditions. The aim of them is to reduce itching and prevent scratching, and oftentimes you'll see they come in all different sizes depending on what age the patient is or what size they are. And even for babies, you might be able to get mittens, little footies, and little head garments that help prevent the baby scratching. Now there are a various range of them, and it is unclear really if the silk garments are much better in effect than the cheaper viscose ones, but as you can see here, from cheapest to expensive, some ranges include Clinifast, Skinnies, Skinny Silk, and Dream Skin. And then finally, sometimes you might just want to use occlusive dressing. So these might be patients that have very difficult discoid patches of eczema to control, or if they've got nodular prurigo, so these thick nodules as a result of their eczema. So you might need to use occlusive dressings to help the extra potent steroid work even better. So these are often hydrocolloid dressings. You apply the steroid and then you put them on top, and you leave them on for a period of time and then remove them. Again, you should avoid occlusive dressings on the face or flexural areas, and one example of an occlusive dressing that is often used is Duoderm Extra Thin. Bleach baths are another treatment strategy we sometimes use in patients that get recurrent skin infections, and the aim of it is to reduce bacterial load such as the Staphylococcus aureus that is on the skin. So you might consider these to prevent recurrence. again, I think the definitive evidence on how effective they are, isn't great, but it seems to be a relatively safe approach to do it, so I do know that lots of consultants do still advocate bleach baths in the appropriate setting. So essentially you want to use pure bleach. I've got just a few examples here that you can get in the UK. So I know Milton disinfecting solution tends to be the one we always say, but there are Tesco Asda ranges, and I'm sure there are others out there as well. And really you want to run a bath with no additives, and then you add half a cup of bleach to at least 10 centimeter depth of water in an adult bath. And for a baby tub, you use about 2 mils of bleach for each litre of water. You then want to mix this very well, and you soak the person in it for 10 to 15 minutes. You can use just a general emollient cream to clean the skin when they're soaking. And it's okay to let them wet the face and hair. It shouldn't really cause harm to the eyes or the mouth, but just make sure the child's not drinking it. And then really at the end you rinse it with plain water and pat the skin dry and apply emollients as you usually would. And you can use this once or twice a week. And I know sometimes parents can be quite alarmed when you suggest that you might use bleach in a bath, but you can almost use the analogy that is making your own swimming pool. So I'll move on to phototherapy now. I won't go into this in huge detail. There is a bit more detail about it in the psoriasis section, but essentially in the first instance you might consider narrowband UVB treatment. Again, it's time consuming and they need to come in multiple times a week for an appointment, and it doesn't tend to be as effective as it is for psoriasis, and they often need longer treatments. Again, it's important to emphasize that they continue to frequently moisturize throughout treatment.